Many of us have questions on anemia in infants. So obviously we need to understand the natural history of the hemoglobin levels in babies. So we have the premature babies and the term babies. First I'll discuss the term babies. So all the term babies have a physiologic drop in hemoglobin as they grow in the first 2 months. This is because the erythropoiesis doesn't start till the hemoglobin reaches a certain nadir, and that's around 8 grams percent or so. And when it reaches this nadir, automatically the process of erythropoiesis will start. So around this 2 months mark is when you start a reversal. Some babies take 3.5 months. If there is a risk factor like a Coombs positive jaundice, where there is hemolysis or G6PD deficiency, the hemoglobin may drop in the immediate newborn period a lower level than what you expect, and in such babies you need to monitor it more closely. One important point to consider here is whether your unit is doing delayed cord clamping or not. So we have clear guidelines from the American Academy, the NRP. Everyone supports delayed cord clamping in stable term babies. Even if the baby is unstable, we can do cord milking if the baby is about 28 weeks to improve. So this is intact cord milking before you clamp the cord. So obviously this will improve the hemoglobin level in the beginning, and the nadir reached may be a little higher compared to the other babies. If the sampling losses are high in a sick newborn, the hemoglobin nadir may be reached earlier. So having a hemoglobin of say 9 to 10 in the end of the first month is quite normal. When people are working up for prolonged jaundice, for example, they notice this and think there is anemia, which is disproportionate. It's not the case. You still need to review the baby and continue to make sure it's rising. If the hemoglobin reaches around 8 or so by the end of the second or third month, that's when you can do a reticulocyte count as well. And if it's rising, it confirms that the baby is starting to produce. You don't need to routinely monitor hemoglobin in well babies. If you do it for any reason and notice it's on the lower side, you may consider repeating it. In the premature babies, slightly different because their blood volume is around 100 ml per kilo to start with, but they are smaller and they grow much faster because a 1 kilo baby, by the time they're discharged, they reach 2.5-3 kilos. It's tripling their weight. And when the body is expanding, the blood volume is also expanding, and they're not producing the red cells at the same time. So the drop in hemoglobin is faster. In addition, we have the sampling losses. So despite our efforts, these babies do need monitoring, and I hope your unit has micro sampling, which will be a big help in reducing the blood volume needed. And try to sample only when needed. Don't do blind giveaway protocol. You can review my video on minimizing interventions, and I can share the link here. So try to minimize the losses and monitor. And we have a threshold for hemoglobin which is becoming more conservative for transfusion. So we don't rush to transfuse the babies, but at the same time, we have to have a balance of not letting it drop too low, because studies have shown dropping it below the conservative thresholds may be injurious to the brain, or it may also increase the risk of NEC in the tiny babies. So these are important points. The nadir is reached faster, and so by the time the baby is close to discharge in an extreme premature baby, they would have received a few transfusions because of the various factors we discussed. But in the bigger premature babies, if they reach a hemoglobin of say 8 or so at around the time of discharge, you do the reticulocyte count along with that. If the reticulocyte count is starting to rise, it indicates the baby is starting to produce their own cells. These are babies we supplement iron in a supplementary dose. So this is not iron deficiency. We're not trying to treat the anemia, but we're trying to support the baby's erythropoiesis. If there is hemolysis, we may add folic acid as well. Whether it helps, we're not sure, but there is no harm. So 0.5 milligram per day dose of folic acid can be added for the babies with hemolysis. So in short, the erythropoiesis starts after 1.5-2 months in premature babies, or a little later depending on the nadir, and in term babies closer to 2.5-3 months. And the nadir reached is different in the premature and the term babies as well. The premature babies may drop lower, and they will start improving their counts. Delayed cord clamping is going to be a big benefit in this aspect as well, in addition to its other benefits of bringing the immune factors from the mother and the hemodynamic stability as well. The risk of jaundice with delayed cord clamping is not significant in routine cases. As the blood volume is increasing, there is no increased viscosity as well in these babies. So I hope this information is useful. Please do share. If you have not subscribed, please subscribe to the channel as well. Thank you.